Welcome into the Eye.Talk.Tech show where we take a look at the intersection of eye care and technology. I am your host, Dr. Griffin Christensen. I'm excited to be talking rapid fire technology in glaucoma today, and we're going to take a look at three key emerging pieces of technology. Joining us here today is Dr. Justin Schweitzer. Dr. Schweitzer is a cataract, cornea, refractive, and glaucoma surgery specialist at the renowned Vance Thompson's Vision in Sioux Falls, where he also completed his residency focusing on the anterior segment, disease, and glaucoma. He's deeply involved in advancing the field, currently serving as Vice President of the Optometric Glaucoma Society, Co-Chief Medical Editor for the publication of Modern Optometry. He's also a Fellow of the American Academy of Optometry, past President of South Dakota Optometric Society, and has published numerous scientific papers focusing on glaucoma treatments and diagnostics. Welcome, Dr. Schweitzer. Excited to have here today.
Looking forward to it, Griffin. Appreciate the invite and excited about the conversation.
Yeah, I'm excited to take a look forward and some technological advances and so forth. But before we do that, I want to momentarily take a look back. Now, I understand once upon a time you had the opportunity to learn under the tutelage of Dr. Leonid Skorin at the Mayo Clinic in Albert Lea during your fourth year. I had a similar opportunity. And I'm wondering if you have any lasting memories from your time at Albert Lea, and maybe we can use that as a launching point, to discuss how glaucoma care has changed during the course of your career.
Lots of memories there. Learned a ton, obviously, as you did, I'm sure. I credit him with really creating the interest I had in ocular disease. If it wasn't for him, you probably wouldn't have been interested in anterior segment disease, glaucoma, cataract care, those types of things. As you know, a lot of other useless information came from him as well, where he made us memorize certain things that had nothing to do with eye care. As I recall, there was a few of those things, but majority of it, 95% of it, was useful information that really launched me into my career in optometry.
I know I will never forget how to spell aflibercept. I got that one wrong on my first day and lived to rue it. So, I want to look, forward to maybe kind of the current state of some of these technological advances. One thing that I think we all appreciate is having objective data in the clinic. We take some of the subjectivity out of that. And one of the things that I want to talk to you about is an objective field. First of all, what is an objective field? And could you walk me through maybe what some of the technology on that front might look like?
Yeah, so the objective field is a new visual field machine that's kind of come to the market here in the last few years, and I've had the opportunity to utilize it a bit. It's really an adjunctive type of technology. It's not going to take the place of your standard automated perimeter. Really, I think of it as something where I utilize it in patients that can't get visual field testing done. They can't take a visual field for whatever reason that may be, or I can't get an accurate visual field, and I'm in a heavy glaucoma practice, and so I have patients that I've taken, 10 visual fields and every one of them is not accurate. And that's really where the objective field can come into play. And really what it is, I like to think of it like a ERG, but it's a little more specific than an ERG. Essentially what it's doing is it is flashing a stimulus onto the retina, and it doing it in the pattern of the 30-2 and the 24-2. And it even does a 15-2. And it has a 90-second protocol, or you can do a 7-minute protocol. And it's testing both eyes, and it's looking at the pupillary response. It's looking at the response of that stimuli on the retina, how it stimulates the retinal ganglion cells, how the pupil responds to that, different levels of stimulus. And so it's like a specific ERG, and it plots out visual field defects, or if there's not a visual field defect and there's no deficit, then it won't plot it out. And it's been very useful in cases, as I mentioned earlier, and I've had the opportunity to dabble with it now and been impressed with some of the structure and function that it's corresponded with, and something, again, that's an adjunctive technology to what we're already using in some of those tough situations.
So this is something that's adjunctive already today. Do you see this as something maybe being the future of how we do fields? Do you think that's a possibility?
I'm not convinced it's the future. I think it will continue to be adjunctive. We have good technology with our standard automated perimetry that's gotten faster and faster. Many of us are using these technologies where we can get standard perimetry tests in 3 minutes, 4 minutes. And so they do a good job with guided progression analysis, all those different things. But I think, as you know, Griffin, a lot of times when we have these patients come in, there's false positives, false negatives, fixation losses, and we're trying to look through data that just isn't accurate. And to have something objective on the market where we can utilize it is very, very helpful.
Now, just thinking of form factors, I know a lot of times patients have difficulty with the mobility aspect of taking a visual field, and I don't have it in my clinic, but I know a lot of colleagues that have had success with the VR headsets. I would love to see with the advent of some of the eye tracking and so forth, maybe we'd have a pupil response that could be gauged inside a headset someday. But again, for today, where do you see the VR headset-based visual fields fitting into the care for a clinician?
Yeah, great question. I think there's a lot of pros to these technologies. We also, in my clinic, aren't utilizing one at this point, but we've test ran and used a bunch of them. I think a lot of the pros involve patients can not have to leave the exam room, or you can do it in a small testing room. So the comfort is great, cost effective for many doctors. Implementing these into your practice, I think that's another real nice thing. Patients comment how they enjoy taking it. I think from a technician standpoint, technicians enjoy utilizing this. I think we still have to have some caution around them. I think we still need to have more data, and you look at the studies around them. On advanced glaucoma, we're probably missing or not seeing as much progression in advanced glaucoma, patients that have significant visual field defects. I think picking up visual field defects, picking up a mild visual field defect like a nasal step or an arcuate defect, they do a nice job on that. The question is, can they track progression accurately or as accurately as our standard automated perimetries? And I think I just need to see more data around that. But I think there's something that can be utilized right now. I just urge caution. Look at the data and be a little bit careful in more advanced glaucoma and tracking progression.
Well, and those are interesting ways of gathering data. In terms of treating glaucoma, I think there's an interesting technology we wanted to discuss here. And can you tell me a little bit about what a direct SLT laser is and how maybe this differs from traditional SLT and some of the data that backs up how this might be effective?
Yeah, this is a very interesting technology, and with optometrists and multiple states doing more and more SLT, there's probably some interest around this. The direct SLT is really, in my mind, a patient-friendly or a patient experience type of technology, but you're still getting efficacy from it. And so there'll be a study that's recently published or going to be published called the Glorious Study, where they looked at the direct SLT and compared it to our traditional standard SLT, and really showed that it was non-inferior. It wasn't worse. It produced very similar results to that standard traditional SLT. Why it's a little more patient-friendly is really it performs a 360 treatment, 120 shots, 1.8 millijoule treatment in about 2.4 seconds. And that's in one eye. And then you switch to the other eye if you're going to do it same day, and it does it in 2.4 seconds. The patient does it typically standing up. You obviously give them a little numbing agent, piperacin, tetracaine. And so just that efficiency and the speed at what it works, and based on the Glorious Study, probably as effective as traditional SLT, I think it could be a win for patients and a win for clinics.
Awesome. Well, that's already here. That stuff's here. I'm sure, if you think back to your time in Dr. Scorin's clinic as a student, you maybe wouldn't have anticipated how fast some of this has changed, and really cool that we can integrate a lot of these things, and cool to hear you chat about that. If you were going to look forwards to tomorrow, what piece of technology, whether it be on the treatment side or the data gathering side, would you love to see? I know what I want. I want to see a continuous IOP monitor. I don't know if that's realistic, but seeing all the continuous glucose monitoring, I'm just curious, what are my patients' pressures throughout the day? Do you have anything like that you'd love to see in the future here?
You bring up a great one. There's some contact lenses being looked at for continuous IOP monitoring. We already know in Europe that there's some ones that are implanted, so I think that's a missing link that we need. We have home tonometry systems right now, but to have something that's continuous, I think is really, really exciting. I think we do need to keep our eyes on, and a lot of the companies are working on, AI to make it much more efficient for us to look at a lot of data, and especially we think about the glaucoma space with looking at all these visual fields, all the printouts that you have, looking at all the OCT technology and all those printouts you have, and how much time that you and I probably spend analyzing these things to determine, hey, is there true progression here? Sifting through that kind of accuracy or non-accuracy. And so some of these AI technologies that are going to help us sift through that so much quicker and make us more efficient, I think is also something I'm really excited about.
Well, Dr. Schweitzer, thank you so much for your insights here. Thanks for being part of the inaugural Eye.Talk.Tech podcast here, and we look forward to doing it again sometime. Take care.